So the first question I'm going to pose to the panel is, in the years during which, in the decades over which we've been considering this conundrum, what movement has there been to try and improve the evidence base in order to inform the development of really robust guidelines? Has progress been made in that area?
You've seen the discussion that I've had with Peter Brocklehurst in the journal about the pros and cons of screening, but the one area that we were in complete agreement within the last decade was the need to improve information about the impact of screening versus risk factors. And indeed, we collaborated with Peter and his group, and GBSS was supportive to try and get a randomized controlled trial funded on the basis of a cluster randomized trial throughout the UK to actually measure the impact. Because one of the objections to screening has always been, oh, there aren't any randomized trials which show that it works. Unfortunately, we could not obtain funding for that. So that's an area that we were in complete agreement that we would all like to proceed on the basis of that sort of evidence. Given that funding is unlikely to be forthcoming, the next question is that funding going to be available elsewhere? And I think that most other countries that have introduced screening are now so committed to it that many of their ethics committees would say it would be unethical to stop screening in places like the USA and so on. So I suspect we're going to be stuck with expert evidence, which is what we've been talking about.
Which is unfortunate, but thank you very much, Phil, for that update. Let me turn to the audience now.
Hi there, I'm Dr. Claxton. I'm a microbiologist over at the Holmington in Hackney. My question is, you say that you don't implement screening till there's evidence that benefit outweighs harm, but where's the evidence from the countries that have implemented screening that there is harm that outweighs the benefit?
I think it's a little bit anecdotal, as a lot of these cases are, and it's around the anaphylaxis with antibiotic treatment. Some of that came out of Northern Ireland, but in fact that wasn't cases specifically for GBS. It was just about anaphylaxis in pregnant women. So I think that's one of the areas of potential harm, but it is a very small area, and there's not a lot of published evidence on that.
There's not direct linkage data, but one of the issues that's brought up increasingly, we know that the development of the neonatal immune system is heavily dependent on exposure to maternal fecal flora, and it's driven by that. So if the maternal fecal flora is abnormal, then that is likely to result in some skewing of the way that the immune system develops in a newborn. Now, one of the things that you will be aware of is that in the so-called developed world, there has been a massive increase in allergy and autoimmune conditions in young children. Asthma, allergy, atopy, food allergy has exploded over the last decade. If you go to Uganda or to other rural areas, actually even in the UK, then you won't find that problem. Of course, in Uganda, you'll find that children die of infection. But we do need normal maternal fecal flora to prime a normal immune system that is regulated. Now, the problem, if we expose mothers to antibiotics, we abnormalize that. Anybody who takes antibiotics will know about the effect on their fecal flora. You get the squits, you're not feeling quite so well, etc. It always will disrupt your fecal flora to take antibiotics. So that is, in theory, a real risk for the newborn. There is no direct linkage data, but there's quite a lot of epidemiological data linking those. Now, the idea, though, is that we reduce antibiotic usage at all in obstetrics, and B, we keep it as narrow spectrum as possible. Now, there isn't the direct comparator data, although it's being looked at. There's a lot of studies in this area looking at whether something as narrow a spectrum as penicillin will be less harmful on the fecal flora than something as broad spectrum as erythromycin, cephalosporins, etc. So there is a potential risk of harm from a potential to increase antibiotic usage. So that's always been used as an argument not to offer mothers intrapartum prophylaxis. However, actually, the published data paradoxically shows the opposite. That if you know whether or not a woman is colonised with group B strep, then actually the antibiotic usage goes down. Because one of the things in obstetric practice, and I think Rona Hughes who's been involved in the previous audit from the RCOG published in 2007, has demonstrated that there is a cacophony of different antibiotics used for a equally massive array of reasons within obstetric practice. And the threshold for using antibiotics is way too low. So, and I don't want to seem to be blaming anybody, but for example, urinary tract infections in paediatric practice, a UTI is defined as there being a pure growth of 10 to the 5 or more organisms in a pure growth of from urine. Now, in obstetric practice, I've got a little bit of dysuria. Oh, let's dip that. Oh, that's got protein in it. Here's some antibiotics. That is such a dangerous practice. So erythromycin usage following the Oracle study, it's used like a Smartie. Phil and I wrote the Lancet editorial in 2008 following the publication of the 7-year follow-up data, which demonstrated no, this is grade A evidence, there is no benefit to using erythromycin for PPROM. How many units still use it? Hands up, please. My units still use it because it's in the RCOG guidelines and I'm the medical director only for a couple of months. So it's really difficult, but we know we've got some other much bigger fish to fry, and we know that if we used penicillin for these ladies, if they were shown to be positive, would actually reduce the burden. So I'm sorry that's such a long answer.
I think, if I'm right, you said the prevalence had gone up slightly from 0.72 to 0.89, but the mortality had gone down. So does the panel have some thoughts to explain why that is? Why has the mortality got down? What are we better at? What's changed?
In answer to your question, yes, that's correct. In terms of the information, and these numbers are correct. So in 2001, the incidence was 0.72, and it's now 0.89, and mortality has fallen. It's fallen across all of the regions. There's been a much bigger fall in the early onset cases rather than in the late onset cases, and again, that's across all of the regions. So whatever we're doing right in the early onset rather than in the late onset in terms of the numbers.
So this is something that Phil and I had a little word. The numbers of babies dying is falling. We don't really know whether that translates into survival that is disability free, though. And if we look at other neonatal data on outcomes, because neonatal intensive care is getting more and more successful at keeping babies alive, and some of us end up in slightly awkward situations where parents won't let us withdraw intensive care, so we end up with some babies who are very damaged who survive for even longer. It may well be that increase in survival, as with other groups of neonates whose survival has improved, that the disability rate is unchanged. So at the expense of reducing death, we may, but we don't have the data there, be ending up with a lot more children with disability. And I think the other thing that we cannot let go of is the impact on families and the patient experience. This impacts terribly on mothers and fathers from a psycho-emotional perspective. It can be very damaging, and as I showed in the first two cases, this is yet another childhood illness where parents sometimes never come to terms with it together and part company.
If I may.
Please. Oh, sorry.
If I may just speak to that. In terms of just talking about the disability, in terms of the way we asked that question to clinicians, the wording was slightly different to when it was asked in 2000, but doing a comparison, it does seem that we have more children who the outcome at discharge was not healthy, as it were. Also, we very much were asking about short-term outcomes. So the question was, did they die, or does the child have major or minor disability? Is it unknown? But also, is it uncertain? And a lot of clinicians ticked uncertain, and that wasn't the same as unknown, and a lot of them qualified that in their responses when I spoke to them, or with what they wrote. And those children who fit into the uncertain category, actually a large number of them, if you wanted to use the word probable, which was what they used in the 2001 study, probable disability, I think they're not completely interchangeable, but certainly they're close. And so that has gone up. So yes, while the deaths have gone down, the non-healthy outcomes has probably gone up. And in terms of meningitis also, again, while the deaths has gone down, meningitis with all that's associated with that, certainly in terms of negative outcomes for the family, has not gone down, and if anything has gone slightly up.
Okay, let's summarise that then. Uncertainty about the outcomes for the babies, both in relation to the newborn microbiome and in relation to healthy survival. If I could take the next question, please.
Thank you. Jane Daniels, University of Birmingham. We've heard a lot about the debate between risk factor-based screening and 35, 37-week culture-based screening, but there is an alternative, and that is rapid intrapartum screening. So I just want to hear what the panel think about that, and whether it should be universal or directed at those already with risk factors.
The problem with that is that it would work very well in some models of healthcare. So in the USA, where, for example, hospital-based intrapartum care is almost universal, and women are encouraged to go in early in labour and so on, I think that there is likely to be a place. Where there is a difficulty in the UK is the increasing tendency of midwives and indeed obstetricians to recommend low-risk mothers having their babies either at home or in midwifery-led units separate from the main hospitals. And even in alongside units, there is a tendency when women ring up to say, oh, go and have a bath or have a walk around. There is a discouragement of women to come in what they perceive as early labour, because sometimes it turns out it's not early labour and they're not actually in labour. And as a result, and again, there is a pressure on numbers simply because the number of births is going up. I mean, perhaps we should remember that although the rate hasn't gone up that much, the number of babies being affected has actually gone up very substantially because of the increase in the number of births, and this is putting pressure on maternity units. So in this situation where we're trying to decentralise a lot of care, saying to women, but we can test you at the beginning of labour, seems to me increasingly impractical for a large proportion of these women. They're not going to have access to it because you need the equipment, you need to take the swabs, and on a busy labour room at 2 o'clock in the morning, is that going to be the priority, to take the swabs and get the test done? I doubt it. And I suspect that we would end up with perhaps 50 or 60% of the women finding out about their carriage status when the baby's already delivered. So I'm not convinced that currently would be a useful approach. Where you could sometimes have a combination is that if women were actually offered screening at 35 to 37 weeks, if they're particularly concerned about it, then you could always do intrapartum testing subsequently if, for example, they were found to be negative, or if they said, well, I'm a carrier, but I want to make sure that I'm still a carrier, and decide then whether to have the antibiotics, then that could well be appropriate, because they will know, if they've already screened positive, to come in early in labour and make sure that they get the test. The danger without doing it that way is that we'll be in the same muddle as we are currently in with the risk factors, which is that everyone gets very confused about what they should do, and we end up not actually succeeding in any direction.
Thank you, Phil. Let me bring Dr. Owen.
Thank you. Just 3 points, really. First, in response to the first question, what effect it has on the baby. There's a recent study that has been published looking at the microbiota of the baby, newborns, and they followed up these babies for a period of 1 year. And now, of course, we got all these fantastic techniques to look at the proportions of different types of bacteria. So what it appears is if you do give specific anti-GBS prophylaxis, i.e. with benzyl penicillin, there is a change in the microbiota of the newborn for up to 3 months, particularly in a group of microbiota called the Firmicutes, which is by and large the largest group of bacteria. But then at the end of 1 year, they found no differences. But what we really don't know is what is the function of these different bacteria. Of course, that is the million-dollar question, and what impact it has in fullness of time. The second point is addressed to the survey that was done by the Royal College of Gynecologists, albeit commissioned by the NSC, is that you looked at, it is a paper exercise in asking people how many people had these guidelines, and you said 94%, and even on a paper exercise, they were not actually necessarily following the guidelines. But in practice, were they actually even following the guidelines that they had written down, they purported to follow? I.e., if you looked at the Northern Ireland data, even half the patients, half the babies with EBE or GBS did not have mothers with risk factors. And those with risk factors, in half the cases, they were not being given the antibiotics as they should. So in reality, a quarter would have been identified and given the prophylaxis by your risk factors. So my question to you is, would your second part of the report, i.e. the one that is going to be released in December, contain that particular piece of information?
It'll contain some, but not all, is the answer. This is not a perfect audit. It doesn't have the answers, and I fully agree with you. It's all about implementation of guidelines, and that's a much larger piece of work that Andrew alluded to. So probably the second part won't give us the full answer. I don't think the audit was set up to give us all the answers. It was just to inform about what is current UK practice. But is current UK practice the right thing?
Hello, Albert Mipset, consultant microbiologist. I mean, so many countries have been using universal screening bacteriologically for so many years, and so many of them have shown benefits that the evidence is so strong in my view. But I think the elephant in the room really is the cost. Some of you have referred to this. Earlier on is the cost of the laboratory testing, the cost of collecting the samples, the cost of administering antibiotics. And what is the other side of the equation? The cost, if you want to look at it cruelly and hardly, of disability. You've referred to a small but not insignificant number of horrible outcome infants with disability. Yet at the same time, we also know that prematurity in itself sometimes has that outcome. Is there any data on the marginal impact of group B strep disease, early onset disease, on disability, and the true estimate of the cost over that over the decades of care for such sadly damaged individuals, some of whom could be avoided?
I think it's a really good question that we don't really have good data on. And I guess part of it relates to just not having the resource to do the study. There is no follow-up of that, and I don't know whether from a BPSU perspective there'd be any health economic data from the current BPSU study.
Not from the current BPSU study. There are a couple of ongoing, as in happening at the moment, studies following up children who had group B strep meningitis and group B strep septicemia, but those studies, following them up at 2 years of age, those studies have just begun, so we don't have the results here.
So in a couple of years' time, there may be an answer to that question, which is an excellent question, as ever, Albert.
We will have Professor Tracy Roberts talking about specifically this afternoon cost effectiveness, but I don't want to preempt her talk. But there have been two major publications in the last 8 to 9 years in the UK, both on the UK situation, one from the Birmingham York group, Health Economics, and the other from Ruth Gilbert's group at Great Ormond Street, both concluded that the least cost-effective was risk factor screening. The most cost-effective thing is either to ignore GBS completely and just deal with the consequences, or to screen and reduce the need for neonatal intensive care and long-term care in that way. The problem with risk factor screening is that it appears to be very inefficient in the way that it works. And so part of the problem is you could say, well, I support risk factor screening if it was implemented properly. But as we're hearing, it's proved extraordinarily difficult to get it implemented properly because it's very complicated and there are too many variables concerned. So one of the big advantages of screening, in my opinion, is its relative simplicity and the fact that women get to know what the problems are and they trigger the correct response themselves. So we'll hear more about it in detail this afternoon. But personally, I feel the evidence suggests that at the worst, it would be cost neutral to implement screening, and probably in the long run it would save money. But you know, it's not just about the money, it's also about the babies and the mothers and the parents and the families who are, you know, desperately affected by this terrible condition, which in so many cases is preventable. And that's, in a sense, what makes it harder for them to bear. If it's something that just would have happened anyway, it's the knowledge subsequently that if only they'd known they were a carrier and if only they'd chosen the penicillin, there's 9 chances out of 10 that their child will be alive and well without any problems. That is really hard for people to bear. And that's why I personally believe that's a choice that each individual family should make for themselves.
My name's Dave Roberts. I just wanted to ask again about this use of the word harm, which seems to be, from what the panel said earlier, based on unsubstantiated kind of chit-chat and opinion from Northern Ireland, which is no longer relevant, but yet we hear it used every single time a question is asked of the Minister or the Prime Minister even in Prime Minister's Questions Time, that harm outweighs benefit. But surely the harm is actually the death and disability, not unsubstantiated bits of gossip and rumour and opinion from Northern Ireland. And I'd quite like to see whether anybody's got any other evidence of harm, or whether we should stop using that word when they are briefing politicians on how to answer the awkward question.
I looked into this because the National Screening Committee, in response to a number of questions about the risk of anaphylaxis, and I would just point out that in the first 1.8 million women given penicillin in the USA, there were no deaths from anaphylaxis. So if there is a harmful effect on mothers, it is extremely rare. They referred to this cluster of cases of deaths from anaphylaxis related to the use of antibiotics in Northern Ireland. So I was able to track this down, and it's since been published, but courtesy of Alan here, he sent me the details. It turned out there were 5 deaths. They were all related to the use of augmentin, a broad-spectrum antibiotic, not just penicillin, for women having caesarean section. So when you're combining an emergency caesarean section with all the issues that are involved in that, with giving a broad-spectrum antibiotic to which the allergy and anaphylaxis is much more complicated, then perhaps one is less surprised to see adverse outcomes. What concerned me was that although this was being used as evidence of harm against screening, not one of those cases was related in any way to the use of either penicillin alone or indeed to group B strep screening. So I think this is a sort of scare tactic which really we should put to one side. The evidence is that in terms of maternal health, it's extremely safe, and remember we are talking about giving it under direct observation by a medical professional, and you've got adrenaline handy in the very rare cases where you might get a reaction. The other point perhaps to mention here, and it was going to come up again in the afternoon, is that a lot of people say they're allergic to penicillin. In fact, there's a paper that's come out just this year which looked specifically, I think it was 38 women that said they were allergic. Turned out that on testing, only 2 of them were actually allergic, and most people say they're allergic when they've had a bit of diarrhea, or they've had a skin rash, or they've developed thrush. This is not allergy, and it doesn't represent serious substantial harm. So we all need to be careful about how we talk about allergy, because I'm afraid that is widely misused in general conversation. Allergy is when you can't breathe, you get bronchospasm, you get laryngeal edema, and that is life-threatening. That's extremely rare.
I work as a midwife in Wales, and I'd like to take a little step back. One of the practice that midwives perform in post-dates women is to perform membrane sweep. In GBS positive women, or in the general population, how does the panel respond to that as a practice? Just to give you a little bit more information, about 9 weeks ago on the labour ward that I work, we admitted a woman who was a multip. She'd had a previous normal delivery. She came in having rung in at about 1:30 in the morning, arrived at 3:30. Membranes grossly intact. She was post-dates, known GBS. The fetal heart was assessed at around about 80 to 90 beats per minute. We took her to theatre immediately for a Cat 1 section. Baby was delivered in very poor condition. Tragically, a baby was ventilated, transferred to special care, diagnosed with GBS. And long story short, baby died 38 hours later. There were no other risk factors, but at post-mortem, the baby's lungs were found to have abscesses consistent with GBS. There had been no prolonged rupture of membranes. In fact, the membranes were found to be intact on admission and ruptured just as we went to caesarean section. This family are actually looking for answers, and the only other factor that we could bring into this was the membrane sweeps that were done prior to her coming in labour. I know it's a very difficult one, but I'm just asking that question this morning.
It's always hard to comment on individual cases. It's a complete tragedy. As Phil says, I don't think there is any evidence that I'm aware of about membrane sweeping. You said she was GBS negative, so had she been screened? Oh, she was positive. Known to be a carrier. Okay.
Yes. Perhaps one can add that antepartum stillbirth is known to be a rare consequence of group B strep carriage. Sometimes women say, well, then if I'm a carrier, then why don't you give me antibiotics during the last weeks of pregnancy? And the answer is that would be treating a very large number of women for what is actually a rare condition. Compared with early onset disease associated with labour, we're talking about perhaps 1,000 times fewer number of cases. So it's actually quite rare for people to get a baby affected by GBS infection through intact membranes. And the problem is, of course, you don't know when that's going to happen. It could be at 35 weeks, could be at 37 weeks. I suspect what happened is it just happened with this lady and this baby in that 24 hours before she came in. And that's always a disaster. But I think that there are extremely unusual, rare cases. And as the lawyers would say, hard cases make bad law. So I don't think any of us would be advocating stopping sweeping for that indication. There are other discussions about whether sweeping actually makes any difference to anything, but that's not for this particular meeting.
And I agree, this is a terribly tragic case. I mean, I have to say, if the baby's got abscesses at post-mortem and died at 36 hours, that those abscesses take days to form, so this baby probably had quite severe infection before birth, well before birth, and particularly if there was a severe bradycardia at 90 per minute on arrival. I think the other thing is that in the data that we've published in the past, while prolonged rupture of membranes is more of a feature with infection, in about just over 50%, there will be prolonged rupture of membranes on the 18-hour, not the 24-hour definition. That still means that nearly 50% don't have either prolonged rupture of membranes or indeed ruptured of membranes at all until the baby delivers. So we know that GBS have got these fimbriae, which mean that they can cross intact membranes. It's a very sneaky bacterium. So I suspect this snuck across, did this some days before this poor lady delivered. And I would imagine that the membrane sweep was nothing to do with it.
If we were to implement screening and women were found to be colonised 35 to 37 weeks, incredibly rare cases like the one you described, and thinking about the effectiveness of intrapartum antibiotic prophylaxis. I think Professor Steer said 9 out of 10. You say that could be prevented. Then one wonders whether women with a positive result at 35 to 37 weeks under the Montgomery principle that you mentioned should be offered a planned elective caesarean section, which opens up another can of worms. If you give me antibiotics, will you prevent it being passed to my baby? No, we can't guarantee that. I'd like a section, because we have to tell them that now.
The only other thing to say is that and I discovered this in the last year or so at my own unit, is that the RCOG and NICE guideline are very clear about stating that antibiotic prophylaxis should be offered at the start of labour. Now, what the start of labour is defined as, it appears to be very variable. And if I ask 10 different people in my own unit what the start of labour means to them, I'll get 10 different answers. If I ask a woman when she thinks she's started labour, that also is a different answer. And so there's I think there's sometimes delay in initiating antibiotic therapy, 2, 3, 4, 5, 6 hours, because one person's definition of the start of labour somewhat differs from another's, including the mother who's in labour.
The only point I can make is when we did an audit of the maternal bacteremias, which is pretty much along the line that was mentioned by maternal bacteremias, they found a substantial proportion also occurred in the antenatal period. And we had, when I did an audit, we found at least 3 or 4 sort of intrauterine deaths in the antenatal period. This almost certainly, and the mothers were bacteremic. So I think it is possible that the baby has been affected antepartum, intrauterine infection, and not necessarily hematogenously, not as an ascending infection, more likely. So I think that has to be considered as one of the ways in which the baby could have been affected.
I wasn't trying to suggest that that doesn't happen, just that it's much less common than getting the infection intrapartum. And secondly, because you don't know when it's going to happen, and we know it's not a good idea to give people prolonged courses of antibiotics while they're pregnant, at the present time there isn't anything we can do to prevent it. So I wouldn't want people to go away and think that that we should be thinking about that as well. I think we unfortunately need more information before we can deal with that.
Right, ladies and gentlemen, will you join me please in thanking the panel? They've given us an excellent morning.